هناك يا نقعد يا نمشي. Please. Thank you. Our session today, this is a session of hysteroscopy. So during the session, we are going to present different hysteroscopic techniques and also the office hysteroscopy and the pain. So we have four presentations today. Each it will be 15 minutes. Try to comply with the time. The first presentation is hysteroscopic myomectomy of large submucous myoma in one-stage procedure using the multiple slicing session technique. That will be presented by me. The second one, hysteroscopic morcellator, is an easy, efficient, and a safe technique in treatment of almost all intrauterine lesions, including myomectomy, presented by Professor Hisham Salim from Tanta University. And the third one is hysteroscopy and ART, presented by Professor Ahmed Abdallah from ENA University. And the last presentation would be by Dr. Khaled Abdelaziz from Cairo University, titled Pain Prediction of Office Hysteroscopy. لو سمحت صوت please. Thank you very much. فحضرتك ممكن اعمل presentation بس كده عشان يعني formality. الصوت مفتوح. الصوت طب خد ده بقى احسن.
بسم الله الرحمن الرحيم. We will start the session about hysteroscopy. The first presentation is hysteroscopic myomectomy of large submucous myoma in a one-stage procedure using multiple slicing sessions technique, presented by Professor Mohammed Zaid, Cairo University.
Thank you. I will try to be quick and concise. Actually, the presentation that I am presenting today would be on the dealing actually with large myomas and the difficult cases. So you have to bear this with me. So we all know that uterine myomas constitute the most benign tumors of the uterus, and it is present in about 25% of the case with clinical presentations. And the most common age presentation would be the third and fourth decade. And we know that we have an increasing incidence. That's why in the infertile patients because of the late marriage. And we know that they present as a pelvic pain or abnormal uterine bleeding, infertility, and recurrent abortions and a preterm labor. And there are different treatment options for submucous fibroids, as we all know, starting from abdominal myomectomy, laparoscopic myomectomy, vaginal myomectomy, hysterectomies, hysteroscopic myomectomy as one-stage or two-stage procedures, and a uterine artery embolization. We all know that the surgical treatment of choice for the submucous myoma is, of course, the hysteroscopic myomectomy, because definitely there are advantages like the no abdominal wound, no uterine incision, much shorter recovery, lower cost, and a better fertility outcome after the surgery. So we know that the indication of hysteroscopic myomectomy for submucous myomas are, of course, the abnormal uterine bleeding, infertility patient, recurrent miscarriages, and a preterm labor, and, of course, the dysmenorrhea and the pelvic pressure symptoms. Limitations, however, do exist for any surgical procedure. So as for hysteroscopic myomectomy, we have to evaluate the surgical difficulty because not all the doctors have the same degree of surgical skills. So in an attempt to identify actually submucous myoma and to try to grade them, we have different types of classifications. The older definition of course, sessile and pedunculated myomas, no longer in use right now, and we use the European Society of Gynecologic Endoscopy classifications. Class 0, Class 1, Class 2, you're all familiar with that, depending on the extent of the bulge of the submucous myoma within the uterine cavity. And it is always mentioned in the literature that if we want to do an easy one, a hysteroscopic myomectomy, then you have to stick to the type 0, and myomas are less than 4 centimeters in size. Selection of hysteroscopic approach definitely would be, you have to consider the size, as I mentioned, and also you have to consider the depth of the invasion or the extent of the invasion within the myometrium. And as we know that you have to have at least 5 millimeters of normal myometrial tissues between the myoma and the perimetrium. And for the scoring system, as a standard right now in the, among all doctors who are performing the procedure, is to use the LASMAR classification, which, although it is not a complete kind of assessment, however, it refers to a certain degree of staging of the myoma according to the degree of penetration, the size of the myoma, the extension of the base of the myoma on the wall of the uterus, and the topography of the myoma in the uterine cavity. These are the main features for the LASMAR pre-surgical scoring system of the submucous myomas. And according to this, a score of 0, 1, and 2 are given, and you have a score actually between 0 to 9. 0 to 4 is considered to be a low complexity hysteroscopic myomectomy. Score from 5 to 6, complex hysteroscopic myomectomy, and the score more than 7 is considered to be a complex, needing actually some alternative assessment or a surgical skill and experience for such cases. However, when you assess the difficulty and the limitation of hysteroscopic myomectomy, you need to look at other things as well. Besides the number of the myoma, the size of the myoma, the site of the myoma, the size of the uterine cavity, the intramural extension, the distance from the perimetrium, the associated pathology and the benefits of surgery, estimated duration of surgery and the surgical skill, and the medical, of course, the medical condition of the patient and the surgical skill. So all these parameters actually are very important to assess beside the usual standards for the assessment. The surgical limitation actually have been changing with the evolution of new technology. We have now bipolar resectoscope. We have better surgical experience. We have precise fluid management system to measure the fluid deficit. We have also the ability to use GnRH for those patients who need preoperative medication. Understanding the pathophysiology of the expulsion of the uterine myomas into the uterine cavity and the immediate formation of uterine wall during resection of the submucous myoma has been something that we have noticed, and we have experienced that, and this helped us to remove myomas that have deeper extension. Intraoperative use of vaginal ultrasound to monitor resection of the deeper myomas. And finally, the morcellator that has been used recently, and I think the second topic would be about the use of the intrauterine morcellation as well. So we will consider the difficult hysteroscopic myomectomy when you have a size more than 5 centimeters, when you have a class 2, which is more than 50% of the myoma within the cavity, within the wall, fundal and low corporeal, multiple myomas associated with intramural fibroids, because as we know, if you have an intramural fibroid, the size of the cavity would be large, and if you large cavity more than 12 centimeters, then probably you will not be able to have a good panoramic view, and you need to get very close to the myoma. Large uterine cavity, high surgical skills will need it, a surgical risk, for bleeding disorders, medical condition associated, and also inversion when you want to perform a hysteroscopic myomectomy without the need to disrupt the virginity. There are some preoperative evaluation. I'm going through this because I need to go with you through that, so that this is a basic of this session about the hysteroscopic surgical technique. You need always to perform office hysteroscopy. Transvaginal ultrasound is very important. Transvaginal sonography, and also the sonohysterography, and MRI sometimes in some of the cases. Transvaginal sonography is our routine, of course, practice. And sonohysterography is very important to delineate actually the submucous myoma, and also be able to look at the site and where it comes from, and also it gives you an idea about the class of the fibroid. It's of course superior than the transvaginal sonography, however it takes a longer time. When you compare this with the office hysteroscopy, of course office hysteroscopy is the essential investigation in evaluating all submucous fibroids before surgery, because you can assess the size, the site, the number, the topography, and the extent of the projection of the fibroid, the associated endometrial lesions, cervical canal abnormalities. Patient interaction is very important part of the procedure. And also, it's a real picture for the surgeon to assess the difficulty of the case and to make the final decision. Also, the site where the tubal orifice is in relation to the fibroid is another important findings that you need to assess. What about preoperative hormonal treatment? This is important because some of the patients, as you know, with the submucous fibroids might have severe anemia. So you might need to control the anemia by giving some hormonal treatment. Also, it may be of value to reduce the endometrial thickness and also to schedule the surgery at leisure. The disadvantages would be definitely the cost, the hot flashes, the higher incidence of recurrence, because you might have what we refer as a sinking fibroid, which is a fibroid reduced in size. And also we have the increased incidence of uterine perforation in some of the cases because of the difficulty in the cervical dilatation. The preoperative GnRH, I don't use it for myself, and we did not use it in the study that I'm going to present in a while. However, it might be indicated for those patients who have severe anemia and have a fibroids that is very large in size and in type 0. However, if you consider type 0, meaning that the blood supply to the fibroid has been always already interfered with, so that the GnRH will not produce an effect. So I would go only for severe anemia. The use of intraoperative vaginal ultrasound to monitor the surgery is an important issue, especially if you are doing large cases, because you need to see how much of the fibroid is remaining for those associated with deep myomas, and it will monitor definitely the expulsion and the formation of the uterine wall. So, hysteroscopic myomectomy, we definitely, in the study I'm presenting, we're using the rigid resectoscope, we're using the bipolar system, and the continuous flow. So this is basically the procedure. You have other options. You have monopolar, you have the laser, you have mechanical rotator. That's the more later. We'll talk about in the next presentation by Dr. Hisham. So actually, what I'm presenting today is a one-stage procedure using multiple slicing sessions technique for larger deep myomas. The technique involves the misoprostol that is inserted 2 hours rectally prior to the procedure. This will enhance uterine contractions and also will help you to have a better cervical dilatation. We use the bipolar resectoscope. The slicing, we start by slicing the intramural portion, slicing the portion within the cavity. I'm sorry about this mistake. And then when you finish with that, you will do a pelvic hydromassage, actually, which means that we're going to deflate the uterus. And when we deflate the uterus, then this will help the contraction of the uterus. You inject a little bit of saline again, so you inflate and deflate. This kind of hydromassage, what we refer as hydromassage, will definitely help to contract the uterus and push the intramural part of the fibroid within the cavity. After you finish with that, with each session of the slicing, you will monitor the inflow and the outflow, and then after that, you will assess the general condition of the patients. This is very important. So we never do more than 10-minute session of a slicing without stopping, reassess the inflow and outflow, general condition of the patient, communicate with your anesthesiologist, and make sure that the patient is in perfect condition. Then you start all over again, slice again the part that has been expelled within the uterine cavity. In this way, larger myomas within the wall can be removed with this technique. We're using intravaginal ultrasound when we feel that a smaller portion is still left, so that, we monitor the amount of the myoma, we monitor the reformation of the uterine wall, and this will be our policy. So when we finish resecting the deeper portion of the myoma and the bed of the myoma has been visualized, then we look upon any bleeding and we use coagulation mode. I will show you in a video in a while, a 7-minute video to show you that. Then at the end of the procedure, we massage the uterus, make sure that a perfect hemostasis is done, and the procedure is complete. So let me show you quickly a video. صوت ولا هنفتح الصوت ازاي؟ في حد يفتح لنا الصوت بس؟
The size and the site of the myoma, as well as the relation to the tubal orifices, are an important.
معلش نبتدي من الاول.
Hysteroscopic myomectomy
علي الصوت
is
من عندك.
one of the most challenging hysteroscopic procedures, especially with large and type 2 myomas. Initial assessment with an office hysteroscopy is important. The size and the site of the myoma, as well as the relation to the tubal orifices, are an important parameter in surgical management. The location of the tubal orifices in this particular case is of special importance because of the close proximity of the tubal orifices to the fundally located tumor. The number of the myomas can only be evaluated by obtaining a panoramic view while withdrawal of the hysteroscope to the level of the internal os. In this particular case, you can see the smaller myoma at the level of the internal os. Hysteroscopic resection of the myoma is done in this case using the bipolar technology, in which saline is used as the distending medium. The large 4 mm loop is used for resection. The generator is set on the VersaPulse mode for the efficient vaporization and resection. For this large type 2 uterine myoma, resection by the slicing technique is continued until the projecting part of the uterine myoma has been resected. Care should be taken not to injure the tubal orifices. As you can see, the loop itself turns red because of the high temperature associated with the energy delivered. Observe the high efficiency of hemostasis associated with resection because of the efficient VersaPulse technology. When a large amount of fragments are floating inside the uterine cavity, it is essential to stop the procedure and remove the fragments, and in this way, a double benefit of allowing the uterus to contract and the deeper portion of the myoma to protrude into the uterine cavity for later excision. The process of uterine contractions and expulsion of the deeper portion of the uterine myoma can be enhanced by a prior insertion of the misoprostol rectally prior to the procedure. Another method for enhancement of uterine contraction is to deflate the uterus. Deflation of the uterus is an important step during the surgical procedure, as it not only it enhances protrusion of the deeper portion of the myoma, but also it allows time for the assessment of the inflow and the outflow and the medical condition of the patient. A sound surgical technique is not to extend the slicing at a time for more than 15 minutes and allow deflation of the uterus in between to remove the fragments and assess the inflow and outflow and the general condition of the patient. Slicing is continued and resection is performed until the bed of the myoma is reached, and this can be known by the pinkish coloration of the healthy myometrial tissue. Resection of the deeper portion of the myoma is continued until the whole myometrial tissue has been removed. It is important at all time during the procedure to monitor the inflow and the outflow and the fluid deficit. Larger and deeper myomas are associated with more extravasation than smaller and more superficial myomas. Using saline, the maximum deficit according to the guidelines is 2.5 liters in case of the bipolar resection. Note the pinkish coloration of the healthy myometrial tissue has been reached, denoting that resection is complete. After resection of the deeper portion of the myoma, it is an important surgical step to visualize the bed of the myoma and make sure of a complete resection of all myometrial tissue. This can only be achieved by visualizing the healthy myometrial tissue at the bed of the myoma. Complete resection of the myometrial tissue will ensure proper healing and reduce the risk of intrauterine adhesions. Observe the proper hemostasis obtained with the VersaPulse and the large loop excision and the bipolar technology. It is important at all times to keep the intrauterine pressure in between 80 and 100 millimeter mercury and not to exceed the arterial pressure at any time. Now the smaller myoma discovered at the level of the internal os is now resected by the slicing technique. Now resection is complete and the visualization of the bed of the myoma will be performed before the coagulation of any bleeding vessels at the bed of the myoma. The desiccation mode and the coagulation of the all bleeding points at the bed of the myoma is an important step to avoid post-operative bleeding. As you can see in this video, all the small bleeding vessels at the bed of the myoma can be effectively coagulated with the desiccation mode and the coagulation. In order to visualize the bleeding points more efficiently, the intrauterine pressure is momentarily reduced so that the bleeding points can be seen clearly. Once the bleeding points can be seen, the intrauterine pressure is increased back again and the coagulation is performed simultaneously to seal the bleeding points. The procedure is completed by inspection of the bed of the myoma, as you observe in this video.
So when we did 49 cases. I'm going very quickly on that. We did 49 cases of large myomas, and the age at the time of surgery was about 37 years. 17 out of the 49 was leprous. 32 out of the 49 were multipurse patients. The size of the myomas ranged from most of the cases have single myomas, 40 out of the 49, and the two myomas, 9 of the 49 cases. The size of the myomas, the mean diameter is 51. The size of smaller myomas, 2.1. The score for the principal myoma, LASMER score, was in 3 out of the 49 was 0 to 4, 5 to 6, 29, 49, and the score 7 to 9 was 17 out of 49. And it's very important to know that the majority of the cases actually was deep myomas, class 2 myomas by the European Society. And most of the indications was abnormal uterine bleeding, and in 17 were infertility. So the results is that the mean, as we said, the mean diameter for the principal myoma was 52 millimeter. In 91% of these cases, actually, we could manage to remove the myomas in one-step procedure. And all the incompletely resected, actually, we did it. They have a two-stage procedure. They were type 2, and they had Lassmann score 7 or more. 3 out of the 4 myomas with mean diameter more than 6 centimeter was incompletely resected. The 4 patients that underwent repeated hysteroscopic myomectomy within 3 to 5 months after the primary operation. 9 out of the 17 infertile patients conceived spontaneously. And we found that doing the multivariate analysis, we found that the one-step complete resection of the myoma was more frequent in patients with the principal myoma smaller than 6 centimeters in diameter, patients with single myomas, and a patient with principal myomas with Lassmann score less than 7, and a patient with myomas with less than 50% extension into the myometrium. These patients, or these characteristics of patients, will lead to higher incidence of one-stage procedure. So our conclusion is that hysteroscopic myomectomy performed by experienced surgeon is an effective and a safe procedure for the management of patients with submucous myoma up to 6 centimeters in diameter. Lassmann score, myoma size, and the number of myoma and degree of penetration seem to be the main factors associated with one-step procedure. Thank you.
Thanks for Professor Mohammed Zaid for his excellent presentation. نعمل discussion دلوقتي ولا الآخر؟
We'll keep the questions at the end of the session. Our next talk will be presented by Professor Hisham Salim from Tanta University, and this is a very interesting topic because it deals with the advanced hysteroscopic myomectomy technique, which is the intrauterine morcellation as an easy, efficient, and a safe technique in the treatment of almost all intrauterine lesions, including myomectomy. Please, Professor Hisham. Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee. I would like to thank Professor Ahmed Abu Nasr, Professor Ahmed Zakaria Sheikha for inviting me for this nice conference. I will take about a new advancement in the hysteroscopic surgery, which is the hysteroscopic morcellator. Use of hysteroscopy has become a gold standard in diagnosing and treatment of different pathologic entities, mainly including the uterine septum, intrauterine adhesion, intracavitary fibroids, endometrial polyps, and abnormal uterine bleeding. They are the main indications of hysteroscopy. Recent technological advances have induced a revolution in the field of diagnostic and operative hysteroscopy. Mainly, I will concentrate about comparing the recent technology